Testing 1, 2, testing 1, 2.
Yeah, I don't know.
Ahmed,
I
Yeah.
just shared a screenshot for him on
well,
WhatsApp.
can he send you his PowerPoint and you can share it?
Okay, sure.
Can you send to Ahmed your PowerPoint, Dr. Ali,
How, by what?
by email attachment or however you can send it?
Ahmed,
However you send files to other people.
oh, okay. You mean I have to send the email, the power?
Yeah, to Ahmed right
to
now.
Ahmed?
Right now. It's a
I cannot
I'm
open
saying,
it from my
It's a
screen.
PowerPoint, right?
Yeah. I cannot open it from my screen.
Send
yeah,
it
no,
by
no, you
email
can.
to Ahmed.
You
Give him
you
your
can do
email.
it. You can do it,
Give
Professor.
him
You
your,
can do it, but
give
it's
him your
just
email, Ahmed, so we can email it to you.
yeah. It's the last choice, but now he can share it on his screen. So try. You can try, Professor, if you don't mind, by the way.
So no, I open in my, I can see you in that one, but it's not included. You know, it's not included in the.
Do you have a smartphone, by the way?
Sorry.
Can you? I mean, can you use a smartphone?
Yeah. No,
If you have Zoom on smartphone,
no.
okay.
Screen. Okay. Usually that in the Zoom, I did several, through the Zoom, but is the moment I open the PowerPoint, it's shown in the
Okay,
screen.
let's try this, okay? One step at a time. Click on the share button on your screen, the share button. Click on it right now. Click on the share. At the
Click
bottom,
where?
at the bottom of your Zoom, there's a share button. Click on that.
Okay.
Click on the share
Share.
button. You're not clicking on it yet.
And then share again.
No, just click on the share button, one step at a time. Click on the share button. That's all you do now, share. Do you see the share button at the bottom of your screen?
Yeah. I did.
Click it. Are you clicking it? Are you clicking it?
No, but it's not shown in the presentation.
Did you click the share button?
Yeah, I did.
Just share.
That's what you're gonna do. The first step you have to do. You have to click on the share button.
I did, but it's not
You're
shown.
not, well, I guess you're gonna have to send the PowerPoint to Ahmed. Okay, Ahmed?
See here now I'm click on the chair, the chair button here. Then nothing is the power unknown. It's seem there the Microsoft PowerPoint is not unknown.
Okay. You can go much more below. You will find the screen.
Yes.
Have you found it?
Yeah. The screen on the screen. Yeah.
Okay. Click on it.
Click on what?
Screen.
Yeah.
Screen
I
choice.
did. Okay, but here when it's come to that the Microsoft PowerPoint unknown, the Chrome unknown, setting system unknown in my this one.
Okay, I'm gonna share.
And
Okay,
also desktop is unknown. It's
how about screen?
screen, the screen here I can see, show sound, share sound.
Ahmed, you're gonna have to get the PowerPoint from him. Okay? This is not
Okay.
gonna work. He has to send. Can you send the PowerPoint to Ahmed, please?
Okay, I'll do.
By email. By email.
Okay.
Okay? You
I'll
got your email address, Ahmed?
Mm-hmm.
Okay, email it as an attachment, okay?
Mm.
You know how to do that, right?
Mm. Uh,
One step at a time, Arthur. He's emailing.
yeah, I'm trying
Yeah,
to
he's
send it to
emailing it.
Ahmed.
Yeah, one step at a time, don't bother him.
Okay.
Okay, did you email it?
Yeah, I'm doing that. Okay.
Okay.
Yeah, I'll do that. Uh, see, Ahmed, I did send it.
Mhm.
You did send it to Ahmed? You sent the file to Ahmed, your PowerPoint file to Ahmed? Did
Yeah,
you
let me
send the
check.
PowerPoint to Ahmed?
Yeah, I did.
Okay, in the meanwhile, let's try to do it ourselves in the meanwhile. Okay, I'm gonna click on I'm gonna show you how it's done. I'm clicking on my share button. You see how you see the screen? I'm clicking on the share. Another screen comes up, it says share, and then I open one of the windows there. Okay, so your first step is share button. Do you see that, how I'm sharing?
Wait a minute. Wait, just
I'm sharing the screen with you. I picked I clicked the share button first. Can you click the share button first?
yeah.
That's a big problem. You're
But
not following the first.
unfortunately, in my screen, when it's seen in the screen here, that is everything is like it's a question mark. Nothing is seen.
Oh,
Seen.
really? Okay, you've never done a
I
Zoom
think,
on you never done a Zoom on
John,
your computer?
John,
I,
your
I think,
screen is not shared yet.
Yeah, we know that, Arthur. We know that. But he can't seem to click on the share button. It's getting no response. So you clicked on the share button right at the bottom of your screen, share. Do you see at the bottom of your screen of Zoom?
Yeah, I did.
You click on it and nothing happens?
Nothing. Just I do that.
Okay, why don't you reboot and come back in? Like turn off your computer and come back in. Okay, can you do that,
Okay.
Ali? Turn off your computer completely, come back in.
Ahmed, did you receive the presentation?
not yet, Professor. Just a minute. And the email, I didn't check it.
Did you get it? Yeah, I mean,
Not yet. And the email. How about WhatsApp? Is that possible on WhatsApp?
you can do it, send it on WhatsApp. Also, Can you send it by WhatsApp, Ali, or the file, the PowerPoint file? Are you familiar with WhatsApp?
No, and no, I couldn't. Yeah, just I think that maybe I have a problem with my in Apple. I have an Apple computer.
No, it shouldn't make it. You should be able to do the same things. You're using an Apple now? Okay, how do you usually send files? Do you ever send files to other people, like video files or anything else like that?
I do, but it's the presentation is in the desktop of this one, my computer.
Professor Mashani, why don't you sign out and restart your computer?
Okay, I'll do that.
Yeah, I suggested that already. Okay, but he doesn't seem to want to do it. So, okay, he did it. Oh, great, great. Sometimes rebooting takes care of problems. You don't know why, but we'll get started soon. We're just asking the main presenter to reboot. Just hang in there. We'll get it going. And if anyone wants to come in the panel, just notify me. Raise your hand in the panel, in the attendee. If you want to come in, just raise your yellow hand. Okay, someone's raising their hand. Maybe it's me. Okay, Rashid, you want to come in? I'll let you in. Or do you have a question, Rashid? Amanda, are you there?
Yeah, I'm here.
Okay, now he has an Apple. Do you use an Apple?
Me?
Do you have an Apple or you use a Windows?
No, I'm just using a smartphone.
Oh, so you don't use Apple?
No, I don't. I
Okay.
just have a smartphone,
Because
Samsung.
because he has Apple. No, normally we have no problems. And Zoom is the simplest one I've seen. But you gotta understand the basics of screen sharing. And turning off the sound at the appropriate times. Be patient. We're waiting on the speaker now to reboot. Okay, Ahmed, do you usually get in contact with Ali? Are you? It seems to be a little while before he's coming in. Ahmed, are you there? Oh, I'll PM you, Ahmed, okay?
Dear John, is there a direct email for this webinar without registration, I mean?
Yeah, Ahmed, he hasn't been around. Can you check with him at all? How do you usually communicate with him, Ahmed? WhatsApp, or how do you email, or how do you communicate with him?
Yeah, email and I mean, here we use WhatsApp, but I mean, if there is a direct contact with him, that will be much more better. Direct email, I mean, to the registration.
Okay,
Yeah.
there he is. Okay. Okay, do you see the share now?
Share. Share again.
Yeah, do you see the share?
Yeah, the share. But here, unfortunately, it's not coming.
Okay, now who has an Apple? Who has an Apple? Ata, do you have an Apple? No.
Yeah.
Okay, you use the Apple. Could you please explain to Ali? Because the Apple interface is different than a Windows.
I'm on Windows.
So everything. Huh?
He has an Apple, right, Ali?
Yeah, right.
Okay, tell him how to screen share, Ata. Can you do that, Ata, or
iPhone bad. Yeah, here something.
you're muted, Ata? And your picture's not on. You need to put your picture on if you can.
Yeah, so I'm on my iPhone.
Okay.
How can I help?
Okay, he's on Apple. Could you please give him instruction?
Okay. So can I share my screen?
Go ahead.
Okay. Okay. So can you see my screen now?
Not screen sharing yet.
Yes?
No, we're not seeing it.
Okay.
You're not sharing it.
Okay. So let me just, I have clicked the share button and now you can see my screen, I hope.
No, not yet.
Okay. Now,
Yes.
okay, this is the logo. I clicked from my files. So it's now visible. If I want to change it,
No, I
so
cannot.
I
I
again
cannot see
share.
it.
Yeah. So when you press the share button, you will see different options: screen, photos, your
He doesn't
That
see the share button.
screenshot.
no, no.
You don't see the share button, right, Ali? You don't see it?
No, I did over that, but unfortunately,
So can you please share it on my WhatsApp?
I
I don't know I don't think he understands what you're saying. I don't understand what you're saying.
no, I'm not
Is
expert.
there anyone around the office, a secretary, another doctor?
No, I'm alone here at home. I'm in the. We are
Oh,
here.
you're
The
at
time
home.
is 9
Okay.
o'clock in the night.
Oh, okay, okay, okay. So no one's around that can help you. And you can't get it by email. I think our best choice is getting his presentation by email. So did you ever get that email, Ahmed? Can you send an email to Ahmed?
I did, but I don't know if he got it or not.
Did you send, okay, Ahmed, can you communicate with him directly to say the best way to get to you, please? Ahmed?
Yeah, I'm hearing you, but I didn't receive any email.
Yeah, can you let Ali, hold on, everybody. Can you let Ali know how to get it to you by email? Please, Ahmed, go ahead.
Just a minute. Let him do it as he want. Okay.
Yeah, send to me an email immediately. I'll try to because I write in your a.a.l, with that at Gmail.
Okay, just a minute. Now.
Yeah.
Okay, and what's the status, Ahmed?
Just reading.
So Ali, you sent him by email? You sent it to Ahmed by email?
I did.
Okay, yeah, could you send it to me? I'm gonna give you my email address. Send it to me too. People are volunteering for you to send it to them. Appreciate your offer, but hopefully we'll. Okay, you see my email? You see my email, Ali, in the chat?
No,
Well, you don't see it? You don't see my email? In your chat, is there a chat button on your Zoom? No, there's no chat button there?
No.
No. Does anybody know if there's a chat button on Apple,
But
on the Zoom on Apple?
I don't know if
Rashad, that's how you can help. Let us know about Apple, not Telegram, Apple.
that I use can I use mail drop? Did you anyone of Ahmed? Did you get anything?
Okay, Rashad, does the Apple have
Not yet.
chat? Does that have chat on the Zoom?
Have you received my message? I just say hi to your email. So have you received it, Professor?
You know,
You want him to check his email, right?
Yeah.
Okay. Yeah, sure. If you got an email from him, he should return it, and that should be it. Did you get an email from Ahmed Ali?
uh,
You didn't get an email from Ali?
wait a minute.
Oh,
Yeah, I did. Yeah, I did.
Oh, you did get the email. Okay. That's where you send the file to. Return. Okay, answer that email and send your file. Okay? Can you do that, Ali?
Yeah, I'll do. Yeah, I'll do. Yeah.
We'll be okay if you do that.
This message. But I did send it to you now.
Okay, send it to me too. You see my
Uh,
email address? Do you see my email address or no?
Well, no.
It's in the chat. I don't know if you can see chat on Apple. Rashad, it won't tell me. Rashad, if you want to help, you can tell me, is there a chat on Apple? Is there a chat on Apple, Rashad? I know you said you had an Apple. So I don't know if,
Well, Ahmed, you get it?
Not yet, Prof. I'm gonna make sure again and again. Not yet, not yet.
I think it seemed to be sent because I see that it's.
Okay. I
You
just
got it,
received
huh?
it now. Yeah, I do.
Okay.
oh, good, you got the PowerPoint? Okay, I think we're on the right path, right? Ahmed has the file, correct, Ali?
Okay. That's a minute.
Once he has the file, we'll be able to go. Okay.
Yeah.
Okay, great, great. That was just a little buildup. Okay, you ready to go? Hold on, hold
Yes.
on, hold on. Okay, you ready, Ali?
Yeah, yes, good. It's
Oh,
good.
don't move the screen yet. Hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. It's Dr. John Bennett for Neurosurgical TV. We had a little problem starting, but we're starting and we're going to finish it. Today we have the Yemen Neurosurgery Club, the Walter Jandy, presenting. We'll let Ahmed Al-Ghanemi introduce the speaker. Welcome, Ahmed.
Hi, dear John. Thank you for hosting this webinar. I'm so happy and so privileged, honored to have this webinar with the number one neurosurgeon in the Arab world as academic, Professor Ali Mashani. He is the president of the Arab Scientific Council of the board program. He was also the president of the Pan-Arab Neurosurgery Society and the Oman Neurosurgery Society. So now it's yours, Professor, if you say anything before present the lecture.
Thank you very much. It's my pleasure to be with you and also with the Dandy Society. I can also share this. Yeah. Okay. From the beginning, who'll move the slides? Me? Wait a minute. First, start from the beginning. Yeah. Yeah. It's my pleasure to be with you and with all my colleagues and also, this group of Dandy. And I hope my topic will get some information more to the audience and participants. So this is supraorbital approach for pediatric tumors. Actually, all of us, we know that is supraorbital approach or keyhole, surgery or supraorbital keyhole craniotomy is popular now in mainly in adults. And this is, and it's most of surgeons, they do it. Although I think it's very important, this topics, because of pediatrics, because the pediatrics, next slide, the pediatric is, it's important for them because the blood volume is so, the amount of blood volumes and also the time consuming the, healing process is different. So we did this approach for pediatric, not only for tumors, but I do it also for aneurysms for pediatric. Yeah, sorry, what happened? Can you, yeah, please, next slide, previous slide. Who's the one controlling it? Yeah, this one. Magnify it, please. It's, but it's with me is very small. I don't know if the others is seeing properly or not. No, that slide. Yeah, this slide. Yeah, this slide. But it seemed to be, it's very small. I don't know. I cannot see it like the normal PowerPoint.
Yeah, they look fine to us. They look
Sorry?
fine to everybody else. Looks okay to me.
Yeah, it's okay now.
It looks okay, right, everybody?
Yes, okay, but I have to. this is the names here to covering part of the slide, yeah? Yeah, shift it to, you know, just, yeah. Yeah, okay. Let us, you know, there is the names of us is covering part of the slide, you know? Okay, it's good now. It's good now. So this approach, actually, just I highlight how is the approach in the surface anatomy and also the important structures, which is we have to consider during our procedure. And that is, which is, one has to take care during the procedure for these, you know, structures. In the surface anatomy, we have the, you know, the eyebrow is here. If I don't know if you see the arrow here, the important structure is the branch of the temporal frontal temporal nerve, and also supraorbital nerve here. That is, I think it's an important during where you have to point your skin incision. With that, the important is this frontal branch of the frontal seventh nerve, also the supraorbital nerve here, and also the orbital bar is important because the inner bar during our craniotomy is important, and this is the type and the craniotomy which is I have to take care. In some, you know, patient, the frontal sinus is large and extend, you know, laterally, and some also it may involve during your craniotomy. So this is an important, you know, structures which we have to take care. The frontal branch of the seventh nerve, the supraorbital nerve, which is also, and also the skin incision and the exposure is important for you to do a small, it's a keyhole or a small craniotomy. And that is, after that, the skin, after we do the surface anatomy on the skin, we have to go in and where we do our incision, and our incision is there, and then we reflect the skin up and also down until we have, after that, the skin, after we do the surface anatomy on the skin, we have to go in and where we do our incision, Dr. John, our incision is there, and then we reflect the skin up, and Dr. John, I think until from the record, I think this is from the record. Hello? You are hearing me?
Yes,
Sorry. Yeah. You are hearing me now?
yes.
Okay. So this is, I'm telling the important structure, which is the frontal branch of the seventh nerve, which is important to take care of. Also, the supraorbital nerve and the amount of skin. And also we have to take where we have the frontal process of the zygoma and also the supraorbital notch, which is we are feeling during on the skin to put, you know, our skin incision. Then after that, we do the skin incision, we retract the skin superiorly and downward to have an exposure which is enough for us for our approach. Then the bar hole, we started, then we take the bone out. After that, we have this structure. It will be in front of us. We can see the, you know, the front, the orbital, the orbit. Before we start to see the structure, we have to trim the inner part of the bone. That is very important during our, using the microscope, that around 1 to 2 millimeters inner part of the orbital bar is very important for our exposure. Then after we cut the dura and reflect it upward, so the part of the frontal lobe is in front of us. Just we take 5 to 10 minutes to drain the CSF. And then the position of the patient, which is, it will reflect also the bone, the frontal lobe backward with minimal retraction. It's a minimal retraction is there. So it will take 5 to 10 minutes, drain the CSF, then the brain is lax. On that, using your microscope, and you can see the structure of the optic nerves, bilateral, the chiasma, the carotid artery, anterior cerebral artery, middle cerebral artery, all the structures you can see very well and in front of you. So there is no much to do retraction on this. So with that, you can remove the tumors in the frontal, in the front fossa, middle fossa, and even you can go from right to left or left to right on that. So you can remove pituitary tumors from that, craniopharyngioma from that, optic chiasmatic tumors on this approach with, with a very safe, way. So this, next slide, please. With this, actually, I give the highlight of the structure, which is important. We have as a surgeons, anybody, even surgeons or non-surgeons, when we have a back in our mind ideas, we try to resist any new ideas. Actually, when I'm going in the airport, we have these ramps. You can see at the end of the stairs, there is a ramps to prevent your bag, big bag, or the trolleys to pass through. Usually, I have to turn my back because I have a false impression in my mind that is my bag will not pass through this, bar. One day, just why not to do it in the normal way? So, and this is in the normal way, so it's passed. So what impression in my mind was wrong. That's why I did change my philosophy from craniotomy to supraorbital approach for these kids. Next slide. So in that you can see the incision here, and that incision you can see a small here. Actually, this case I take it first because my registrar, he was shaving the hair. Before I come, he thought I will do terional approach. He didn't know about the supraorbital approach, but we did a supraorbital approach for the same. And with that, we have a small craniotomy. Just this is the skin incision. Here you can see the supraorbital nerve. Here it will be here, and the frontal branch of the seventh nerve will be somewhere here. Yeah. So with that, next, just click again. Can you click again? Yeah. No, not zoom. Just click as other slide. Yes, you can see the skin here. This is now the craniotomb. This is the bone which we have to take it out, and we can see from there our approach. Next slide. Yeah, just click again. Another one. With that, you can see this. You can have a huge, view with that small craniotomb. So you can see the skin here, incision. You can see the bone here. You can see a huge, just huge view with your microscope. If you want to use assistant endoscope, you can use. If you're far away or you just do with microscope, it's very good, and it's a very nice approach. Next slide. So this approach, actually, there is a lot of papers on that is when they are starting, and this just some examples on Journal of Craniofacial, and that is they show that the structures in the anterior middle fossa can be reached with this approach. Next slide, yeah. Also in the world, no, the previous one. Also in the review of World Neurosurgery, they review literature, and that show that is this approach is less invasive, and also can be used after conventional craniotomy. Next. In the neurosurgery journals, also that it show that is not an important, it's less effect in cosmetic. It's very good in cosmetic, just because some surgeons, they say that is the incision there is very ugly for in the face and so on. And I think it's not with them, because some of the patient, even after skin incision, you cannot see within almost 1 year, you cannot see the skin incision, depend on the patients, but it's very good cosmetically. Next case. Okay. So in minimal invasive neurosurgery journal, that is show that supraorbital approach is considered to be a safe and effective route for recurrent or residual supracellular tumors. Next. We reviewed, actually, we did around 8 cases in this procedure, and we sent it and published it in American Journal of Medical Case Reports, and that is for pediatric in tumors, and this is the journal. Next. I'll give you some of the cases. Actually, this is some of the cases which I'll demonstrate it to you. And usually our colleagues, what they will do is they will take a biopsy, then some of them radiotherapy, some even chemotherapy, which is not effective. But I will show you some of the cases, which is, I think it's a very effective procedure in the same time, and can be cured, some of these cases. And this case, which is an 8-year-old boy with the left optic chiasmatic glioma, I operate, this is his MRI. You can see the tumor here, and this is the left eye is blind and extending to the chiasma and to the other eye. And you can see, if you can highlight, it's here, you can see the skin incision on the eyebrow on the left eye. And this, there is no, after total removal of the tumor, he see with the right eye, and left eye is blind even before surgery. And the patient last seen, I operated on him on 2012, and now after almost 12 years, there is no recurrence, which is, I think this is a good to remove a tumor with this approach. Biopsy is not enough. I think craniotomy is a good procedure. Supraorbital also is very effective also in this case. Next. This is another patient with hypothalamic chiasmatic bleed glioma. It's a bleed. She become almost blind, and we did. You can see the craniotomy. This is after 4 years. She's on the replacement, hormonal replacement, and this is post-op. She's take care of herself. Unfortunately, when she came, she is blind. But immediately, the moment she lost her vision, the father brought her to the hospital, to emergency. We took her next day, and we did the supraorbital approach. And this is after, on hormonal therapy. This is, after 4 years from the supraorbital approach. Next. This is a 2-year-old girl with the loss of vision in the right eye, and in the left, she is only light perception. Actually, I explained to the parents, because we thought this is a craniopharyngioma. I thought it's not It's not a glioma tumor. It's a craniopharyngioma. And I told the family, if it's a craniopharyngioma, the surgery is successful usually, and the patient will, inshallah, will regain some of the the vision. After we did a supraorbital, you can see the skin incision here, and this is the second day, next day within after 24 hours, and we did the supraorbital approach. The moment we reached the tumor there, we thought we got it as a glioma. I talked to the parents, either we have to quit and later on we remove, or we have to take it, the tumor again. The mother, she said, please take the tumor, because the cure is not with your hand. The cure is from the gut, from Allah. So we did, that is the one. Next day, you can see the trim here of the blood, fresh blood. This is second day post-op. Fortunately, the child, she is seeing with the left eye, the right eye, she see with the right eye. Left eye, it was light perception. The left eye is seeing completely, but his right eye, she light perception, she again. Yani light perception in the right eye and full seeing with the left eye, which is, we cannot explain to that. But when we did the CT scan, you can see a trim of blood here taking the pathway of the optic nerve and the chiasma. This is, we thought it's like a miracle, but is, I cannot explain it medically. But I examined the patient, my colleague examined the patient, the patient is seeing, which is, I cannot explain this, medically. But the only thing we can explain is, can this blood take the pathway of the perception? I don't know, because the faith of the parents, I don't know. Next slide. We can remove with this approach a huge tumor like this. If you can see this axial, coronal, and sagittal tumor, huge like that, with 12, this is a 12 years old girl, and you can pre-op here and post-op here. This is, we remove total the tumor of this patient. She is, she came to the clinic, she was taking care of herself before she can light perception, but she can take care after the surgery, because we can leave the tumor, remove the tumor, but you can see the trim of the optic nerve and all the chiasma, and that is, which is an important, approach for these patients. Next. This is the patient. Actually, this is a PowerPoint, but it's unfortunate it's not working. She's taking care of her, I asked her to where to go and sit. This is the nurse, which is standing with her, but it's unfortunately this, video is not working. You can, before, yeah. You can see the skin, incision here. Yeah, you can see the skin incision here. Next. Yeah. This is, which is a 6 months child. 6 months child, girl with history of fail to thrive, cachectic, decreased vision, unable to sit, and hair weight only 3 kilos. If we did the MRI, this is hair MRI. You can see the huge tumor here, sagittal and coronal. Next case. Next. Yeah. This is the axial cut for this. See the 3 kilo, the blood volume of this kid is 240 mil. If we do, a conventional terional approach will not reach without transfusion that amount. You can see a post-op, we remove this huge tumor. This is a post-op MRI. Next. That is the sagittal pre and post. Next. You can see also the optic there. You can see this is a child, the 6 months, 8 kilo, 240 ml of blood. So with the trional approach, you will not reach there without transfusion. The moment you transfuse, the blood coagulation effect it will be affected. So with this one, you have only drops of blood, so you can, take the tumor, and during the taking the tumor, you can transfuse the patient if you have loss of blood during that time. Next. In this supraorbital approach, I think it's an excellent approach for pediatric. It's very effective and time-consuming less, minimal blood loss, fast recovery, and I recommended it for pediatric. Adult, as I know, as already I said, is a routine in some centers, but is in pediatric. I think it should be popular. With this, I would like to thank all of you, all the people. I'm sorry for the inconvenience from the beginning. By the way, this is our south of Oman. This is a river, you can see, and now it's raining. These days it's raining. And this is, just a picture. And the people are using some small boats here. Thank you very much.
Okay, Ahmed?
Thank you, dear Professor. I'm so happy to have this lecture with Your Excellency. It was very informative and very helpful for us, as it inspires us as we are, exciting to be much more professional neurosurgeons in the next few years, inshallah. So that is very inspiring for us. Thank you so much.
Thank you. If any questions, some audience or somebody is...
Excuse me, John, could you look for, Bayam? I don't know if she joined us or
She
not.
doesn't want to come in. I tried to admit her, but she doesn't want to come in. Okay, any more questions or comments? I'm sure we do have some.
Look, I think, just a minute. Okay. Okay, just John, could you add a panelist? Could you add Bayam for the
Okay,
panelist?
I've tried. I'll try again.
Have you found Bayam?
It's the third time I've tried to get her in. But are you in, Bayam? Are you in?
Yeah. Oh.
Hold on. Bayam, are you in? Perhaps not. Okay, I think we have a question. Do you have a question, Ata Bhatti, Dr. Bhatti?
Yeah, Professor Mashani, excellent talk. I just wondering to know what your preoperative work for these cases. Do you do MRA, CTA, or in selective cases where you suspect vascularity? Would you consider PSA? And
Yes.
is your center equipped with the neurointervention?
Yeah. Our center is, is a referral center all over the country in Oman. Our center is, we have intraoperative CT scan, we have 2 navigations, we have MRI, 2 MRIs, we have, intervention, diagnostic, as well as coiling and also embolization. We do that. We depend most of the time in CTA or MRA. And sometimes if we are, in doubt, we do, DSA. And, our colleagues with neurointervention were also with us. Some, I did not present to you some of the aneurysms, which is we did clip. I did clip it with this approach in pediatric as well.
Great. And how is your population dynamics and your case workload? And-
Our population in Oman is around 4.5 million.
Okay, and your case and your faculty numbers and your case flow, especially
You know,
for pediatric neurovascular cases
you know,
and
we are
oncology.
in the center. That is our center. We have we have five centers neurosurgery, but is the main center is ours, but is the other centers for usually we do it for emergency because far away from the capital. So one of is around 1,000 kilometers from the capital, and that is for emergency and any tumors. They will refer to it adult or pediatric. I do pediatric as well as adult myself and also my colleagues, and and some of my colleagues as well. We do a skull base, we do a vascular, all this, and we are 2 units. With each unit, there we have 3 to 4 consultants in each unit. In addition to that, a total staff in our department is around more than 20.
Okay. We have a couple of questions by Mohammed Isam Al-Haz. Go ahead, Mohammed. You're on the air. You have a couple of questions, right, Mohammed? Okay, well, he asked, what's the best incision, sub-brow or supra or middle of eyebrow?
That is depend. So sometimes I do it in the people, they do it mainly in adult, and that is it's not shown much, but in pediatric it will disappear. You do it at the end of the hair or within. That is it's at the end of the hair up. I think the incision is very important, but sometimes during when you did your your marking and you put your sticky papers, when you start your skin incision, you'll find it later on. It's not the where you put it actually in the marking bin. Sometimes it may go to the hair itself, but it's the best is at the end of the hair.
Okay, Mohammed has one more question. He says, any tricks for close craniotomy or use of absorbable plate in pediatrics?
Yeah, I did not use blade in pediatric. I use just the thread itself. A thread is good because the blade itself it's the very thin, like I show you one of that the 3 kilos. The microblade itself is not holding, even it will not hold, like some of the case, but in big children in 12 years you can use the microblade. We have it in the theater. We have a microblade. We have sometimes we use it, but it's in the younger use this one, use the suture.
Okay, any more comments, questions? Okay, man. I think, go ahead. If you have questions, go ahead.
I want to just tell you that Bam is waiting to be in the bell list. So could you add her to the bell list, please?
Yeah, for the third time. I don't know if she's going to come in. I'll invite her.
Well, let me check about the questions, if there is any question over there.
Okay.
I think you have talked about titanium avoidance.
Hello, everyone. I'm very sorry for the technical problems I was having. I was having trouble joining the meeting as a panelist. Even now, I can't really open my video for some reason. So I really apologize on that. And thank you so much, Dr. Al-Mashani, for this wonderful webinar. And thank you so much, Ahmed and John, for covering everything perfectly. And thanks to all of our participants for joining. If you guys have any more questions, please feel free to drop it in the Q&A box, and we're going to address them while the doctor is here.
Okay, I think he's pretty well. Do you see any, Ahmed? I think he's answered most of the questions.
The last one is talking about the titanium avoidance. Is that what you talked about? Professor, can you hear me?
Yes, sorry.
Have you talked about the titanium avoidance as someone asked about it?
Titanium, you mean microplate, you mean? Titanium, the amine?
Someone asked it to avoid, here, I don't know what is the question was, but he said to avoid titanium non-absorbable in ground skull. I don't know what is the question. Just say that.
To, I don't know if he mean that is, yeah, I mean to use this stitch absorbable or non-absorbable. There is no, it's available. There is absorbable microplates. It's available. They're absorbable type, and there is also the microplates, which is titanium type. That is the one. I think it's not make much difference to this, but it's usually in younger. I try to avoid a blade in general. I use the stitch because that is the one still the bone is growing, and I don't want to restrict.
And here, Rahim asked about the specific complications regarding this approach in children.
Specific what?
Specific complications for this approach.
The complication is there, like the other complication. Yeah, I mean, there is infection can be there, and just leak can be there, but also that is the one, vital structure or whatever it is, trauma or so there, seizures but in general, I have I'm using this for last 15 years now, this approach. Actually, I got one infection child, and then after that we treated him with antibiotics, and then we did the cosmetic with our colleagues, because it's look the skin a little bit wider than the normal, and the plastic do a cosmetic reconstruction. That is the one. This other there is no other complication apart from there is one case or two cases CSF leak, but it's with the pressure it's disappeared.
Okay, thank you. Here is Faiz Ubaid. He thanked you and asked you about the difference to apply this with adult patients.
Oh, this is as common. This is actually many centers they do it in adult. In adult it's common in some of the centers. But it's I give these talks because in pediatric is I don't know if that is when I published that. I did not get it found it in any of the publication for pediatric. That's why I did that. This is I published it, but that is I advocate this approach in pediatric because of the time consuming, blood loss is less, cosmetic is not that important, and it's not ugly to as some people they advocate, but it's very effective, especially in young, because the blood volume of these kids is very minimal. If we do it with terional approach, you will transfuse the patient without reaching even the tumor, and that is affect also your coagulation and also bleeding during the tumor when you are in. So in this approach, there is only just a drops of blood, if that 1 or 2 mil, if that is with this one, because you have to be meticulous, and also you are direct almost to the tumor. rather than reflect the skin and the bleeding from there.
Okay.
I received one last question, before seeing if there are any other questions. So now we know that the pediatric brain tissue is often softer and more prone to shift. And because the supraorbital approach is a narrow approach, how do you maintain the navigation accuracy during tumor resection, especially after draining the CSF?
Actually, we are not using, I have a tool navigation in my theater, but is with that no need to use a navigation. If you have, because you are working in the skull base, and that area, you know where is your anatomy, and with this, you know where the structure is. Not like in the convexity or in the, that is with when you open the dura, the brain will be shifted, and that is, this is different than the other one. I think we never use navigation, although we have to navigate in the theater.
All right, nice. Thank you so much, doctor.
Okay,
Are there
Bayam,
any other
okay,
questions?
yeah, okay, Bayam, I think Ata Bhatti has a question. Do you have a question, another question, Ata?
Yeah, for the sake of juniors, would you like to give tips for positioning as well as saving the frontalis nerve, or what you do and what you advise to juniors?
The position is important in this one. As we know that is, above 2 years, you can use the 3-pin, and you can just some extension with slide around 10 to 15 degree. This one rotation to the other side. This is a one with, just not a hybrid, with extension, and that is to make the brain retract by itself and reduce your retraction on the brain. This is very important. The other thing is, you have to be meticulous from the beginning. That is a one for the blood, because these kids, the blood loss is very important to you, more than to remove the tumor. The second is also important is to take, just don't be hurry not to start drain the CSF until have enough the brain, it will lax and it will retract itself. And the application of retraction, it will be minimal. It will be just supporting without, make a pressure on the brain itself. This is an important. The moment you use your microscope, you have like a ternional approach. Like a ternional approach, whatever you want to see, it will be the same. Because the ternional approach, the only thing, you do craniotomy, you expose more of the brain to the air, and that is lead to dry the brain with time. This is, but your corridor is the same where you are now, you are doing your craniotomy. This is the corridor you want it. You don't want to remove whole bone and to reach that, because you are going to the skull base. And that is the one you need a small corridor. And that is a corridor which you are doing it, with the supraorbital approach. The other one, you will not need it.
Agreed. Thank you. I fully agree that this is the versatile and workhorse approach for us. And it's amazing. Okay.
Okay, very good. Thank you, Ata. Okay, Bayam, do you want to wrap it up, please?
Yeah, sure. So thank you everyone for joining, and a huge thanks to Dr. Ali Al-Mashani for taking from his busy schedule, just in order to teach us and give this webinar. Huge thanks to the Neurosurgical TV and to you, Dr. John, and of course to my colleague, Dr. Ahmad, for handling everything from the start while I was having technical issues. So thank you everyone once again, and we hope to see you in future webinars. Have a great night.
Thank you very much.
Thank you, everybody. Thank you,
My
everybody. Thank you,
pleasure.
Dr. Ali. Thank you very much.
Dr. Ahmed. Thank you, Dr.
Thank you.
John. Thank you.
Thank you.